Have you ever been on an airplane and you hit turbulence and the whole plane goes, like nobody can say no to that. It's the same thing with breathing. We need our breathing to be passive and not turbulent. We as dentists shouldn't be feeling like we're putting out fires all the time. We should be patting ourselves on the back for being quarterbacks of not just the oral cavity, but of full body health as well, if you're looking at things with an airway positive spin.
This is an ENT issue. This is a dental issue. But the body has no idea what you've studied. It has no idea what your specialty is. It's just functioning or dysfunctioning the way it is.
In this episode, I'm joined by two dentists, Dr. Liz Turner and Dr. Meggie Graham, who started as general dentists, but then have later niched or pivoted more into airway and health. They still do dentistry, but they're very much an airway focused passion. I think passion is the best word. And let me tell you guys, you're going to absolutely love the different themes and facets we explore. The thing I love the most about this episode, which I know you will too, is how it made airway tangible. For example, when I ask my patients, what do you do? They will say something like, oh, I'm in logistics, or I am a project manager, or I am a business consultant. Honestly, I could not even shut my eyes and imagine what they actually do. Like, I want to know what people do day in, day out. I don't know if it's just me, but I genuinely cannot imagine what a typical day in their life looks like and how they actually operate. So similarly, when someone says, oh, I'm a dentist, but I have an airway focused practice, I actually didn't know what that actually looks like day to day. So one of the questions I asked them is, okay, what does a typical day look like? What interventions do you use? What different tools do you have in your toolbox to help your patient? And I think they both did a wonderful job to explain that. And you'll see these 5 patients discussed, like 5 typical patients that they see, that we see day in, day out. These are 5 real patients. The 5th one being my second son, Zehan, that we actually discussed, who we can help as dentists, but their primary issue is an airway issue. So I love how we made it tangible. Now, this episode is part of the AES takeover. We are shining a big light on the AES conference in Chicago. That's in February 2026. The website will all be below. And this is where the creme de la creme come together in occlusion, TMD, and airway. Me and Mahmoud will be speaking at the conference, but honestly, the lineup is insane. I definitely want every single person to click on that link to AES. I've got my show notes and have a look. Does this tickle your fancy? Have you never been to Chicago before? Let me tell you, it's an amazing place. Great culture, great food, but just come for the education alone is going to be mind-blowing. Hello, Protrusive, I'm Jazz Galati, and welcome back to your favorite dental podcast. Every PDP episode, I give you a Protrusive Dental Pearl. And this one was inspired by my conversation with Liz and Meggie. Before we actually hit the record button, I was talking about one of the missions this podcast has is to help dentists fall in love with dentistry again. And we need to remember that the kind of themes we're talking about, the discipline of dentistry, which is airway that we talk about, is growing, and is growing for good reason. And it reminded me of how not only our life, but our career also comes in seasons. And we need to appreciate that dentistry is a wonderful profession in the sense that we can redefine ourselves or be reborn like every 10 years. Think of it like that. Like every 10 years, there could be like a season of your career. For example, for the first 10 years, you could be focused on general dentistry. The next 10 years, it could be general dentistry and facial aesthetics. And maybe in the 10 years into that, it could be just facial aesthetics, for example. Should you wish for that? I'm giving quite extreme examples on purpose. For someone else, it might be single tooth dentistry for the first 10 years. Then it could be for the next 10 years, full mouth dentistry. And for the last 10 years, it could be periodontally focused alongside full mouth dentistry. And of course, you can think of every possible combination. You can bring in implants at 10 years, or you can start doing more ortho. The most important thing here, guys, the lesson I'm really trying to share here is don't stay stagnant. You will get bored. Keep learning, keep growing, keep pivoting, keep niching. Get rid of the elements of dentistry that you don't like and do more of what you do like. And give everything a chance though. Like sometimes we're too quick to give things up just because we're not good at it. Maybe you're not good at it because you were never taught well. And so maybe you want to go on that education to be a good generalist first and then niche in to the areas that you love. So think of your career as coming in seasons of 5 years or 10 years, however you want to play it. And don't stay stagnant. Keep learning. Keep growing. And with that, let's listen to what Liz and Meggie have to say. I'll catch you in the outro. Dr. Liz Turner and Dr. Meggie Graham, thank you so much for making time on this really important episode for so many reasons, because we get to discuss career and passion and changes in our professional lives and the different facets of dentistry that often we can explore more and more. And really, I want to just shine a light on airway in a big way. And I'm so glad you're here to do this. So Liz, we'll start with you. Where are you speaking to us from, and tell us about yourself?
So I'm in Denver, Colorado. I am a general restorative dentist. I have a huge focus on pediatric growth and development because I just think that's where we can make so much change. We work with so many adults, but at the same time, a lot of what we're doing at that point is symptom management. And to get across the finish line is just a little more challenging. Where if we could just be preventative in our mindset, we can reduce so much hardship that people experience in their health journeys. So I am just so excited that our paths have crossed, and that's mainly through AES. So I am just really excited for anybody that's listening that is considering coming over across the pond, as you guys call it, to Chicago in February. Our meeting is going to be awesome, and I'm just so excited to have Jazz and Mahmood on our lineup.
It's an absolute honor, I tell you. It's crazy when I think about it. I'm very excited for that. Liz, question, do you treat just young people or do you still treat adults? And then do you do any restorative at all?
Yes. So I have two practices. I have this Airway focus practice, Untethered, which Meggie and I share from Denver and Milwaukee, and hopefully we'll see that grow in the best way possible. I also have a general restorative practice where I focus heavily on functional, restorative, airway focused dentistry. So I am able to utilize my clinical skills on the daily with an airway positive approach. And we're able to plant the seeds in our hygiene chair and really work hard in educating our patient population who's just asking for more. And it's not uncommon for me to hear, you know what? I asked my dentist about that 10 years ago and they said I didn't need to do anything. Or somebody pointed that out to me. I just didn't think it was a big deal, and neither did they. So we're really running into this time where patients are coming in so much more informed, and they're asking for more of us as clinicians, not just to do the best anterior restorations possible, but why can't we improve upon the foundation as we're doing so? It's just a really fun time to be in dentistry. And I'm just so grateful that my personal path has taken me that way. And I think Meggie feels the same.
Well, we'll be discussing the journey, but Meggie, please tell us where you're talking from today and your experience are you only seeing children now? Do you do any restorative?
Hi, I'm Meggie Graham. I'm in Milwaukee, Wisconsin, also across the pond. Like Liz, I have two practices. One is a restorative practice where you come and you have your hygiene visits, you come in for restorative dentistry, but we do have that mindset of getting to the root cause and focusing on functional restorative smile design. And then we also have the specialty clinic, which is Untethered, where everyone that comes to Untethered has a dental home where they go and see their hygienist and their general dentist, but they're coming to us to seek out answers to their questions about sleep and breathing and facial development and growth. So we have very parallel situations where there's a restorative practice and the specialty practice.
What I love about everything we're talking about and everything we will be talking about is it's a way of putting the mouth and dentistry back into medicine overall, right? Back into the body, which is such a huge thing. I'm way early on in my sleep journey and airway journey. I have been sleep testing for just 2 years, but the difference I've been able to make already on my adult patients, I don't see children anymore. I'm especially eager to learn from you both about how you manage your day in, day out, the kind of questions you get from patients, how you're able to influence and impact and help all your patients. But I just want to start from the journey. Right? I just want to spend a couple of minutes on the journey, because one of the purposes and the missions of this podcast is to help dentists fall in love with dentistry again. And dentistry just doesn't have to be class 2s and crowns, right? The most beautiful thing about our profession is we can pivot and we can niche into a million different ways. So I would love to hear your niche stories. Something I talk about on the podcast is niche kebab. For every one thing that you want to add, you remove something, and eventually you end up with a little niche kebab of, that just defines you. So Liz, tell us about your journey. How did you fall into this scope of dentistry?
So I had some facial trauma when I was a kid, and I ended up in the dental chair a lot. And we didn't talk about prevention. I just thought you got cavities. It was not a thing to have my parents, no offense guys if you're listening to this, managing my dental hygiene. It was you're 12, you brush your teeth. I was like, heck yeah, I did. Yeah, right. Did I? No. And in terms of diet and prevention, it just wasn't a conversation in our household and really amongst the population. So ended up in the dental chair a lot, had some facial trauma. And I'm still managing all of that because the foundation was never appropriate to start. And so ended up having a dentist. I was a distance runner. I guess still am, retired, recovering. But I always appreciated the full body approach to health. And so I'm 8 years into my career. I think to myself, well, okay, another root canal, another extraction. another crown, but it was single tooth dentistry. Like there had never been, I went to Tufts Dental and I had a great education, but it was basic. It wasn't heavy on occlusion. And the general consensus was that the occlusion guys were crazy. And really it was the big picture that we needed to look better at and really emphasize to our students. So finally, I think I'm in the wrong space. I should have been a physical therapist. I should have been a chiropractor. So I'll admit I was doing well, but I was pretty unhappy with the way that my journey was shaping. And then I had my son and stuff started to shift because I didn't know much about babies, but he just seemed different. Like he just seemed cranky and fussy and uncomfortable, but he was healthy. So nobody really cared. And I started asking questions about tongue ties to a provider that I knew out of school who had posted some things about a laser. And she goes, I can't diagnose from a picture, but that baby's got a pretty significant tongue tie. And I'd been told in the hospital it was mild. We'll see if it affects his speech. He's gaining weight, don't have pain. So it was just so dismissed. And there was so much gaslighting behind it then, and there still is now. So fast forward a month, I have him treated. 3 days later, my father-in-law has a heart attack due to years of undiagnosed sleep apnea and eventual AFib that he developed. And months later, I start putting the pieces together. And he's got a bilateral posterior crossbite. He had a speech impediment that still affects him today at the age of, he survived miraculously after being put in a medically induced coma. He still got a speech impediment at 80. And it bothered him when he was a kid. And maybe if we just looked at his growth and development, we could have improved his breathing and ultimately the way the story ends. So we don't have a crystal ball to say what's going to happen for everybody. But as I've seen my career evolve, I've realized that if we can help children breathe, we can help adults breathe better too. So it's been just a really fun progression. And a lot of it, Meggie and I, self-admittedly, that's how we met, is like we had to figure a lot of it out on our own. And it's been really fun to develop our own way and our own nuances and share those with ourselves. And now we're just really excited to share them with everyone else.
The two words I wrote there was health optimization. You are in the health optimization space, which is amazing. And Meggie, your own personal journey, we always love to hear them. So Liz, thanks so much for sharing that, some personal details. Really appreciate you sharing that. And everything aligned and pointed you, the universe was sending you that sign. Meggie, how does your story go?
I mean, so many overlaps, so many parallels. And I think a lot of people in this space, in quote unquote airway dentistry, have similar, at least some overlap on a Venn diagram of similar journeys. But mine started very similarly as a new general dentist. My dad was a dentist. And I remember very profoundly, this is one of those memories that stands out. I was on a walk with him shortly after graduation. And I just said, Dad, I think I made a huge mistake. Like this, I cannot imagine doing this for the rest of my career. It is so unfulfilling. It is so high stress. It is, people don't like to come to see me. I'm causing pain. I feel like I'm putting out fires constantly and there's no real satisfaction. I was a single tooth dentist and, I just kind of sat there for a while in regret and doom and gloom. Like you said, I love that phrase. And I just leaned heavily into starting to ask the question, why? So many patients would come in and we were taught in dental school, or at least my takeaway from dental school was home care and diet. Those are the things that patients can control. And that's what causes all of the problems. And that didn't add up to what I was seeing in my clinical practice, where some of my most fastidious patients coming in on their prescribed recare, every time I saw them, they had another broken tooth or they had another set of caries and something wasn't adding up. And so I kept on asking why. And that led me to my CE journey, which really reinvigorated my passion, which is lifelong learning. And that led me to occlusion. And I really laid heavily into learning and understanding the function of occlusion. And then it still didn't quite add up. Like there still was something missing. And that led me to our mentor and friend, Jeff Rouse, who really connected the dots that there is a component to this that is systemic. The mouth is not annexed from the rest of the body. It is related to breathing and sleep. And so then that just kind of kept me going. And my friends thought, maybe they still think I'm crazy, right? Like the amount of time, energy, and money I was spending on collecting CE for the first decade of my career was insane. I was dragging babies with me and I couldn't consume it enough. But like Liz said, there wasn't a clear-cut path for us of how do we take all of this knowledge and then go home and implement it. And so that's kind of how I fell into it. And then, of course, personal stories, my nephew, myself, I realized I was the airway patient, my own children. And then once something becomes really personal, you can't help but just grow your passion to figure it out. And then I started to see that in my patients. And so my shift in focus went very heavily into sleep and breathing and airway. And I let go of the restorative dentistry to the detriment of my practice, to the detriment of my staff. I lost patients. They're like, I just want a cleaning. And so I had to kind of find that middle ground where we can create curiosity and ask questions and plant seeds in my patients. Because I had consumed all this information didn't mean that everyone else had this. And so really figuring out how can I take all of this and get it to people so I can actually help and not scare them away was that next phase of my journey. And then as I continue to change my focus, we have figured out how to kind of marry the two in our own way. And Liz and I have done so many things in parallel that we finally were like, what if we started doing this together? What if we took your path and my path, we married them and made a bigger impact and also learned from each other and did this faster?
We just started sharing so much information because we needed to almost teach each other, like, oh, I figured this out. Can you teach me how to do this? So even from an administrative standpoint and what type of forms and how do you work with insurance? And I know you guys have a different system, but like that's one of the biggest questions we get asked by dentists in the US is how do you manage billing? How do you manage this administrative portion? So it's challenging to know all the things in dentistry. And like you said, Meggie, it can be challenging to not be fulfilled when you're always putting out fires.
I mean, very much what you're doing with Airway is the exact opposite of single tooth dentistry. It is bringing everything together, which is what I love. Now, to explore that common theme that you both have discussed, so, how it's affected you and your close family members. I love my restorative dentistry, right? I also get a lot of referrals for TMD, and the last few years I've implemented Airway testing, like sleep tests, and I'm looking more and more into this. Very fascinated. My now 6-year-old, when he was about 2, 3, I noticed that he was not breathing at night. He was holding his breath while we were sleeping. I was observing him holding his breath. And I was like, something isn't right here. And went to the doctors and they're like, yeah, he's growing. He seems like a fine. And I was very insistent that, look, is there no diagnostic test you can do? And they reluctantly did a sleep test and lo and behold, they found that yes, there is an issue. He had his adenoids removed and he's a different boy. And my 2-year-old is now 2, but when he was 1, he also had the sleep test. He actually got even a higher scale, moderate sleep apnea. For at that point, he was age 1. And he snorting, he's disturbed sleeping. Sometimes I have to wake up 6 times a night to get milk because that was the only thing that would pacify him. I was like, something's not right here. He's like 9 months old. Why am I having to go get milk? This is after he stopped breastfeeding at age 1. And then now he's being monitored. And when he's healthy enough, again, going down the same path of adenoid removal, potentially tonsils. So I've taken a great interest to this. But what this ties into is when I see the dentist Facebook groups and classically they mention about, oh, I have a child patient and the parents are concerned about X, Y, Z. And then often there'll be, oh, bruxism. And then you have a whole 20 different opinions, many of which are, okay, ENT, there's nothing to do, ENT, right? And one of the things I'd like to discuss with you, because, you guys are experienced in this, you guys are developing this fantastic niche, is at the point of the GDP, we're like, okay, it's an ENT or a sleep specialist. And the misconception is there's not really much the dentist can do. So please explain about, is this a misconception? And then develop that more for me.
Can I go?
Yeah.
Okay. One of the things we've noticed, Jazz, is that we're both so excited and we're both so overlapped. Like we're both ready to jump in and talk over each other. So we've learned to be very careful at answering questions. Can I take this one? So, it's yes, both, right? And all of them. It's not, and I think we've done such a disservice to humans and patients to compartmentalize the body and say, this is an ENT issue. This is a dental issue. But the body has no idea what you've studied. It has no idea what your specialty is. It's just functioning or dysfunctioning the way it is. And so you have to have a really full, comprehensive understanding of the whole system, even if you're not going to treat all of that. And what I think has made Untethered really special is we are really good at quarterbacking or stepping back and seeing the whole picture. And yes, we offer services to help our patients. And we also recognize that sometimes it's not our services that are needed first. So when I first jumped in, and I mentioned a minute ago that everyone was an Airway sleep patient, and to the detriment of my practice, I was Airway testing, sleep testing everybody. And I realized I don't do that as much anymore. I still do sleep screenings and sleep studies, but now I recognize if we can optimize function, which in an infant or a child might be breastfeeding, speaking, eating, we can optimize breathing. We're going to optimize growth. And so if you can just optimize function and the foundational structural components, TMD symptoms fall away, breathing symptoms fall away, bruxism falls away, and then the sequelae like dental breakdown falls away, and all the systemic things that come from poor breathing and sleep fall away. So a really long-winded answer to your question is yes, ENTs are appropriate if the ENT can look at the big picture, because so often if they go and see the ENT and they're told no, they don't know where to go next. And that's where I think we really want to get providers to is how can you go to 12 different providers across different specialties and get the same information, right? Like the full body understanding.
I think that's the hardest thing. And Meggie, what you're basically saying is you can still just do the dentistry. Like you can still just do dentistry and make positive change. Because really a lot of these systemic problems have dental manifestations, or what came first? Did the dental manifestations cause the systemic problem? So what came first, the chicken or the egg? It doesn't matter, because you're right, the body doesn't know the difference. So if there's not space, make space. If the teeth are worn and we've lost vertical and we realize there's an etiology of sleep apnea, doing that full mouth rehab is beneficial to the patient from a health standpoint as well as aesthetics. So like we as dentists shouldn't be feeling like we're putting out fires all the time. We should be patting ourselves on the back for being quarterbacks of not just the oral cavity, but of full body health as well, if you're looking at things with an airway positive spin. So it's a challenging time, because you're right, there's so much disconnect. And even for me, my most favorite and most understanding of development craniofacial wise, ENT, I'm finding out now is requiring a sleep test on everyone. And I can't get people sleep tests for 5 months. And 5 months, if that was my kid, that's too long for my child to suffer. It's within, at least in the US, it's within our ENT's guidelines. If there's an alteration, if the adenoids of tonsils are causing an alteration to craniofacial growth, it's within their guidelines to look more closely at just the structure and not the data on the sleep test. Because also the data on the sleep test, the cognitive effect of if you have an apnea score of 10 or 1 in a child, the cognitive effect is exactly the same. The severity doesn't relate to the fact that negative change is occurring in that little brain. So that's where I just get a little irritated with medicine in general, but there's my soapbox.
Taking it back to your question, Jazz, about your own kiddo and these Facebook posts of understanding that there are ways to jump in and do even without a positive sleep test or without an ENT. So we get a lot of people that are searching for solutions, and giving parents the power to know that they can make a ton of little changes, and all of those things can add up while you're seeking out the more structural, bigger picture things, looking at function, looking at how they're chewing, looking at their diet, looking at the quality of the air that they're breathing. All of those things can impact them very positively while you're seeking out a provider in your area that has that whole body understanding, whether it's an ear, nose, and throat doctor, an airway focused dentist. But yeah, really starting to understand that it's just not a yes or no answer.
About taking what I'm gathered from that is being more proactive and the bigger picture, and being part of a multidisciplinary team where you can call the shots a bit. Well, again, actually this patient will benefit from an opinion. We're working on this together, and we'll talk more about which other specialties are involved. I'm going to explain the next two questions, because then it'll revert back to the first question, which is I want to actually know what you actually do, right? And what I mean by that is it reminds me of patients, right? Like in my mind, I can shut my eyes and imagine what they do, what a typical day looks like. When a patient tells me, oh, I work in logistics, or I'm a consultant business, whatever, I can't even close my eyes and what do they actually do, right? And so the reason I ask that is I would love to know, if I say restorative dentist, okay, but I would love to know in a typical day, how do you actually structure your day? What are you actually doing? What are the different interventions, diagnostic tools, that kind of stuff? I'd love to know. But that is a follow-up question to first, we need to understand what the signs are, what the symptoms are that you get, parents tell you, that children tell you. What are we actually looking for, which will then help to explain, okay, what then is your role? What tools do you have at your disposal to actually help these patients?
Do you want to go with the symptoms, and I'll go with what a day looks like?
Sure. I think that's great. Well, even in the name, you asked what our journey was before, and even in the name of my practice, was my practice and is now our practice, it started out as Untethered Tongue Tie Center, hence the name Untethered to Untethered Tethered Tissues, but then realized that is one positive sign of many possible things that we could be dealing with or seeing. So tethered oral tissues is a big one, and it's going to impact how our muscles function, which is going to impact how we do everyday things like chewing, speaking, swallowing, and that's going to impact the way our structure grows, and then that's going to lead down to everything else that we deal with. So tethered oral tissues, we're looking at facial development, the shape of the face, the position of the jaws. Intraorally, we're looking for some of the complaints we might get from patients are TMD pain, facial pain, continually breaking teeth from bruxism or clenching, uncontrolled caries, narrow vaulted palates that are...
Can you explain uncontrolled caries, just so because younger colleagues may be listening to this, where wait, caries is plaque and sugar. Why is it that an airway patient will be more susceptible to caries?
Great question. Yeah, and it took me actually you some time to get there too, is so like in my journey in school, it was home care and diet. You brush your teeth and you have a clean diet and you avoid sugar, you're going to have a healthy mouth. And that is very true. Home care and diet are essential and they're very important. I don't want to say that that's not the case. And if you don't optimally breathe through your nose, if you are somebody that has restricted nasal breathing, you're going to have an airway that's more collapsible, and that creates a vacuum pressure. And that vacuum pressure brings up acid. And that acid is not like gastro acid where we feel heartburn or feel discomfort. It's a mist and it's asymptomatic. It's laryngeal pharyngeal acid. And that creates a constant acidic environment in our mouth, which is what cavities or decay thrive in. It also produces a signal to our body that we have an acidic environment, and we start to brux our teeth. And that bruxism is to produce saliva to buffer the acid. So now we're bruxing in an acidic environment, and that's causing significant erosion and attrition in the mouth. So uncontrolled caries is that there's a breakdown despite the effort going in by the patient's own accord.
How about the fact that mouth breathing, like the saliva quality would be less, dry mouth, is that part of it?
Totally. So that's one part. So like, let's say, because some people are like, oh, I don't mouth breathe. I breathe through my nose, and yet they're still showing signs of acid and erosion. Those are still airway patients. Then there's more overt patient that is mouth breathing. They're bypassing their nasal system. They're not filtering their air. They're making their saliva a different quality. They're drying out the mouth. They're creating an acidic environment. That also increases the cavity risk as well. So it's coming at it from two different mechanisms.
And you were listing all these symptoms. I'll let you finish for any more, but then I would love for you to tell our listeners and watchers which ones are perhaps specific for younger patients, children, and which ones are more specific to adults.
So as we grow and as we age and as we mature, we adapt and the symptoms can change. And so the common thing that Liz will talk much more articulately about than I can is many providers, myself included years ago, would say, oh, they'll grow out of it. Don't worry. It's not a grow out of it. It's a symptom adaptation and a dysfunctional change, and the compensations change. So we can see increased caries or decay in children and adults. We can see erosion and attrition in adults and children. So that doesn't really line up with age specifically to those types of symptoms. In a child, though, we're more likely, somebody that is a child that can't breathe and therefore can't sleep very well is more likely to show signs of hyperactivity and behavioral issues, because when they're underslept, that's how that manifests. Whereas in adults, it's more common to see, not always, but more common in an adult than a child to see profound fatigue, excessive daytime sleepiness, just this wrecked, crushed fatigue. So those symptoms do show differently between adults and kids. And then like you experienced with your own son, in a baby, it's cranky, it's fussy, it's in a hyperactive fight or flight state all the time.
Absolutely. So Liz.
So I'm going to give you 4 patients, because I think when you look at the patients, you can look at the treatment options and also understand the symptoms a little bit more and kind of how a day operates. And think about it like this. Meggie and I both started our practices. Untethered was within the dental practice, and that's no longer, but this stuff is possible in a dental setting. But what I would encourage you, if you're listening, is to start to compartmentalize your brain a little bit of, you don't, and like Meggie said, losing patients, losing friends. You don't have to go all in all the time. Like, we can plant seeds in our hygiene operatories, and that'll be patient 4 for us today. But you can actually do this well within the walls of your own practice without having to have 2 facilities and a whole separate team and all these things. So, okay, so baby number 1, referred over by a lactation consultant and a chiropractor, had been seeking and asking questions about why the baby took so long to feed and why they would fall asleep. The pediatrician says, oh, just flick them on the foot or take their blanket off so they're cold so they'll stay awake. Okay, so you got a really, really sleepy baby while they're feeding. At 3.5 months...
That was my firstborn. That was my firstborn, by the way. My wife tried her best to breastfeed. About 4 to 5 months she did it, so well done to her. But then it was like this issue of him falling asleep and not thriving, not doing so long. My secondborn was a fantastic breastfeeder. We had to force him off the boob because my wife needed to go back to work after a year. So yeah,
he's your one that wanted the milk a little too late because he's keeping that tube open with suction. So that's why breastfeeding slowed down at 4 or 5 months. Baby comes to us 3.5 months, supplies tanked, baby's super frustrated at the breast. We're starting to decline in weight, and using the bottle is working to keep the weight up, but the baby's super uncomfortable because they're taking in so much air. Mom's supply tanked because it switched from hormonally driven to supply and demand, vacuum driven. And since the vacuum wasn't good because the oral cavity wasn't working, maybe there's a tongue tie or lack of tongue tone. The palate's narrow because genetically we're going that way. We need to work on infantile suction from the first day. And we do a disservice to babies and moms because the swallow pattern is what drives growth of the upper and the lower jaw, especially the lower. In the first 2 years of life, we get more jaw growth in the first 2 years of the mandible than we will at any other time. And anybody that says they can grow a mandible consistently, I don't know if you got a person. We're missing a huge growth window if we don't optimize function. So baby number one comes to us. We treat them through, they've already had a lactation and chiropractor. They're in a good space to be moving forward with tongue-tie treatment. Laser frenectomy, they return a week later. We make sure symptoms and healing is appropriate. So there's patient one. Patient two, 4.5 years old, has seen ENT. The adenoids and the tonsils aren't big enough to be removed, but hyperactive, snoring, lack of sleep that is disrupting the family as they've had to lock the child in the room because they'll come into the parents' room so much. So they wait for him to start screaming on the camera before they help him because the ENT said there's nothing they can do. And they've been asking questions about this kid for 4.5 years. So what do? We're super narrow. The lower teeth are tipped in. There's not a visible crossbite because it's compensatory. But if you look at the maxilla, it's smaller than the mandible. And we need that hat to be bigger than the mandible. So we expand them. And we can get statistically significant shrinkage of the tonsils and the adenoids with expansion. The question is it enough to reduce the need for tonsil and adenoid surgery? They were already told no tonsil and adenoid surgery. What choice do we have? Let him suffer or expand him? Upper palatal expander, improve the nasal breathing.
What age are we talking here, Liz, for patients? What age are we talking?
That's a 4.5-year-old. In a perfect world, I'd wait closer to 6. Typical orthodontics. But I still like the concept of fix before 6 when I can. But if I've got a kid who's sick, I'm not going to let them suffer because no one else said they could help them. I'm going to inform the family there's going to be some relapse. You're probably going to need a second incremental palatal expander at some point. But I want your child breathing and growing and releasing human growth hormone and healing that brain as quickly as humanly possible. So there's patient number 2. Patient number 3.
Hello, YouTube Protrusive. I know you're watching on YouTube, and I hope you're enjoying this episode so far. But I wanted to highlight, in case you don't know yet, we have an amazing viewing experience on protrusive.app, our website, our network, our platform. So I just want to spend a minute to show you what this looks like. On the left side, you see the navigation, and when you join the app, you get a 1-minute video tour of the entire network. Now, in terms of where the magic happens, that's in the Protrusive community, because you might come for the content, but you'll stay for the community of the nicest and geekiest dentists in the world. We have all these polls, we have a chat group, there's always active chats and dentists helping dentists. And really what I want to do is create a really supportive environment that's not like the environment we have on Facebook, and it's built on the values of niceness and geekiness. If you are nice and geeky, you belong here. Now, to make this a safe space, we have a manual process of approval. We actually verify that you are a dental professional before you get in here. So we have hundreds of applicants a day. So if it's been about 2 days and you haven't heard anything, either something's in your junk or you need to reach out. If you're still waiting to join your tribe, email marie@protrusive.co.uk. That's MARI@protrusive.co.uk, and she'll investigate what's happened. Now, all the videos you have on YouTube are also on here, but you actually have some extra ones for free that you don't have on YouTube. So you get some bonus content that's not on YouTube. And actually for the future, I'm not taking things out of YouTube, but some things are not appropriate for the wider public, and I want to sort of safeguard that information, which is like dentist talk, if you like. So that's why a lot of the content is only here and not on YouTube. So you're kind of missing out if you're not on here. That's why I'd love for you to join there. And if you join one of our paid plans, then what you get is access to the CE quiz, like this one, and you can get CPD or CE certificates, and also you get our premium notes. So these are a great aid memoir or revision for an episode to really cement your learning. And whilst we have ads and YouTube places ads on YouTube, we don't have that on our network. So for the paid plan, you get to see all of the premium notes without any of the ads. And of course, you get to support Team Protrusive and help us to continue what we're doing. I'm just going to gloss over the Protrusive Vault, which has all our infographics and downloadables. These are all our masterclasses at this moment in time, and we're always planning to add more. And if you look at them, there's about 1, 2, 3, it's about 7 of them. But actually, if you look at the replay section, some of the live masterclasses that I've done and some of the training that people pay for on other websites is all on there, included as part of the masterclass subscription. And if you're a student, don't fear, we have a special section for you with all the student notes, which anyone can access. So for example, here is one on exodontia. So it's all there waiting for you on protrusive guidance. Please head over to the website, which is protrusive.app. Make an account on your browser. This could be Safari, Chrome, however you want to do it. And once you've made your login, then you can download the iOS or Android app and then log in through there. So the reason to make the subscription primarily on the website first is that you get access to a free trial, which you don't get if you do make an account on Android, iOS. If you make it on the website, you get access to the free trial and you get our best price if you sign up through protrusive.app. So our best deals and free trials are only on protrusive.app. Of course, we always put the link below in the description. And thank you so much for enjoying our videos on YouTube. But it's now finally time to level up your experience. Back to the episode.
Great.
I'm loving this, by the way. I'm absolutely loving this. You're making it tangible. I'm loving these two patients so far. But then, so this, the expansion. Okay, so this is going to be brilliant. So for the first one was actually diagnosis and managing parents and helping a child to feed better and a tongue tie release, right? Did I get that right? Second one was, again, diagnosis and education. And this was, expansion at the age of 4.5. Brilliant.
3D printed expanders go in like a dream. So my boy, tonsil and adenoids weren't quite big enough. His AHI was a 10. That's not good. We expanded him. We took his AHI to a 1, so sleep numbers. But then he relapsed because we couldn't correct the breathing. So we did some adenoids, tonsils on top of that because I got him breathing better for a little while, but it didn't solve the whole problem. And that's kind of where this interdisciplinary care comes in. It's one thing is not always enough. Sometimes it is, but each little step here is incremental. So that tongue tie release in the baby could have prevented the expansion at 4.5. Maybe we could have started expansion at 7 on that second kid. Okay, so patient number 3. You got a 32-year-old female. She complains of migraines. That's not her chief complaint. Her chief complaint is TMD pain. She's narrow.
How old? Sorry, did you say how old she was?
32.
32. Okay, fine. So.
She's narrow. She has abfraction recession on her maxillary dentition. She has a thin biotype. She has been clicking since she was in orthodontics, and now it's coming to a head and it's causing discomfort. Her mandible is locked up. And why is it locked up? Because it never grew to the correct spot, and the orthodontist lined everything up, and now we've got this beautiful smile, but it's dysfunctional and uncomfortable because she's got a restricted envelope of function.
Can you explain for our younger colleagues, what does a locked up bite look like?
So how many class 1s do you see that have TMD issues? Like class 1 bite, so a normal bite on paper, which should be functional. Yet we've got people that are class 1 that are chipping their anteriors that, and you'll go and you'll repair an edge. And then 3 months later, oh, your bonding failed like right after I left. Like your bonding sucks is basically what they're trying to tell you. Like what's really happening is that path of function is compromised. The path of function does not have enough rotational space because the mandible is likely tucked back, the condyle is posterior displaced, and maybe they weren't dysfunctional and uncomfortable until that mandible, that kind of like tiger in the cage concept, that mandible wants out. It's got nowhere to go. So it's either breaking teeth or it's causing myofascial and or internal derangement of the TMJ complex.
Can I throw something in there? Like that's the patient, Jazz, that like if you put them in a mandibular advancement device or you put them in an anterior deprogrammer, those are the patients that are the most at risk for developing a bilateral posterior open bite. Because finally they're uncaged and their jaw is like, nah, I'm not going back. Thank you. Right? Like I don't want to go back to that dysfunctional jam back position. My CR is actually forward.
Yeah. So some schools of some occlusion camps would call this a constricted chewing pattern, a CCP.
Correct.
And so I love these analogies as well. And uncaged is a great way to put it. Being really locked, a lack of wiggle room, a trapped mandible by the maxilla. So this is the kind of theme we're exploring. Please continue with patient 3, 32-year-old.
So you'll see that in kids too. They'll posture forward because they're trying to get out of their tonsils. The tonsils are in the way. So
this is my second born, and we'll talk about him a little bit more later because I'm actually genuinely more curious about him, and he can be patient 5. We'll come to him.
Yeah, sure, perfect. So I'll give you my decision tree. So 32, she had ortho. She was, and ever since then, the jaw's been clicking. She played soccer, so she got hit in the head a little bit. So the ramus length is a little bit off because she grew not on the disc, is what many of us would say. So what do? She's not breathing well through her nose. So we start some lip taping because she's able to. She can breathe well through her nose when she's at rest, but when she goes into sleep, her lips part open. She realizes her migraines decrease the symptoms of them with just lip taping and better nasal breathing. But now she wants more. And so I tell her, if the lip taping doesn't work, come back and see me in 2 months and let me know how you're doing. She wants more. She's asking for more. She's asking for more treatment. So what do? We go ahead and we refer her to myofunctional therapy to work on that tongue posture and placement. We start considering tongue tie release to release some of the tension in her tongue to better able live where it's supposed to. And we start thinking about some type of expansion in adult, which is possible. There is orthognathic surgery, which is patient 4, but patient 3 is a candidate for enlarging the entire craniofacial respiratory complex through maxillary expansion. So we put her in a MARPE, mini implant assisted rapid palatal expander. Really, the current protocols are to go very slow. So there are some people that are calling it a mini implant assisted slow palatal expander, which makes way more sense. And we expand her and make the hat that sits on top of the mandible larger. We give her that improvement in her ability to function well. And then restoratively, we fix some abfraction lesions that were popping out on her over and over and over again, because now they're not.
The cool thing about that patient too is we get so many oral cavity volume improvement. It's unlocking that lower jaw. It is increasing the floor of the nose, so it's decreasing nasal resistance. So by just making that one change, we're checking multiple boxes of improvement. And yeah, the facial aesthetics is really cool. I was like, I like my cheekbones better now.
I have a MARPE.
It's amazing to know. Oh, wow. You have one on right now?
Sure do.
I used to have one. All the cool kids end up getting them.
I got a cute little gap here. I mask. I can show you.
I mean, very good. And I like it that you talk the talk, but you walk the walk. Like when I'm making occlusal appliances, every single one I've done, whether it's a mandible advancement or for their bruxum, whatever, for their TMD, I've had it on myself as well. So it's great that you guys practice what you preach on yourself as well. Now, patient 3, like I love that you're talking about lifestyle. I love that you're talking about oral posture, anatomy, function. These are the very basis of our healthcare, right? Can I just probe you further on the mechanism? Because it's not the first time I've heard it. The mechanism behind mouth taping, then allowing you to breathe better nasally, which can then help with migraines. What's the connection there? What's the hypothesis on how that works?
Have you ever been on an airplane and you hit turbulence and the whole plane goes, like nobody can say no to that. It's the same thing with breathing. We need our breathing to be passive and not turbulent. And what happens when we nasal breathe is we release nitric oxide from our paranasal sinuses, which is actually a vasodilator. So it gets more oxygen to our tissues. It's actually a treatment for erectile dysfunction because like breathing, that's a problem for that too. So this is, again, a full body concept. So nitric oxide release is essential to health. The nasal breathing, it filters, it humidifies, it warms the air that we breathe. When we nasal breathe and we get that nitric oxide release, we kind of get that double whammy. If we're mouth breathing, what also happens is that turbulence of the airflow causes that collapsibility that Meggie was talking about. So it's twofold. You're missing the health benefits of the nitric oxide and the filtration and the cleaning of the air, but you're also getting the turbulence of the airflow that's sleep disruptive and not supportive. So many of our patients, especially those upper airway resistance patients, are going to wake up at 2 a.m., 3 a.m. They're going to have to go to the bathroom. That's why they're getting up. And then the weight of the world is on their shoulders. They got stuff to do. And it's because their body is in fight or flight mode. And it has been for years. These are our anxious patients, our depressed patients, our patients who feel like they can never get enough done because there's so much brain fog. So like the trickle down of the symptoms from not nasal breathing is substantial. It's not just tonsil and adenoid enlargement in childhood. When we don't grow out of it and we grow into it, narrow and open mouth posture or class 3, we're not going to be breathing well in adulthood, and that will have a systemic effect. And so mouth breathing will help with getting the oxygenation to an unoxygenated area, the TMJ complex, and it will help the brain heal.
You said mouth breathing, you meant nasal breathing will help.
Nasal breathing, yeah. Yep. And so a lot of people will support and get proof of concept from mouth taping. And it's kind of fun because it's become really mainstream now that it's been on some of the reality shows. Yeah, TikTok.
Well, I will say that the other thing to consider with that too is like I can breathe through my nose. I can sit here and I know I've trained myself through myofunctional therapy to feel wrong if I'm mouth breathing during the day. At night, your body's going to find the path of least resistance to breathe. And for me, with a narrow nasal passageway and nasal valve collapse, I default to mouth breathing without the tape. And for some of us that have already grown into a suboptimal foundational structure, we need a little bit more support. So in addition to mouth tape for adults, I will also recommend some sort of nasal dilator, like an
I
internal...
literally wrote that on here as my next thing because I saw the ads for it and I was like, this seems pretty cool, right? And like I tried it myself, and obviously your nose goes like really, really wide.
Yeah.
And it felt great. I was like, wow, this is what breathing feels right.
For sure.
Is it normal for it? Should it be feeling like that?
In combination with mouth taping, because you can keep your mouth closed, but if your nasal passageway is still restricted, you're not going to get that full effect. So those two things together are really impactful.
It's just one more way to decrease the resistance that's occurring internally. And like Meggie said, when we go to sleep, habitually we can become mouth breathers because we have been for a lifespan, but our muscles also go into paralysis. Say, for example, that tongue is down and back because it's always lived there or it's substantially tied in adulthood. It doesn't, A, have the strength to live up there or the mobility, but it's also going into this phase of sleep. That's where a lot of our upper airway patients are REM sleep disrupted. And so the manifestations of that long-term health-wise is it can be Alzheimer's, it can be cardiac, because we're working hard to combat a disease that's been underlying for a lifetime.
And we're not
like you
getting
said,
restorative sleep cycles. Yeah.
that health stability, I use the phrase, I want to bring harmony to your system. I want your system to function in harmony, because right now something is working harder. Your neck, shoulders, your nasal passages are working harder than they need to be. They're not working the way they were designed. So does that answer your question?
Emphatically. And I just want to say, just a theme, something I learned from one of my mentors is at dental school, we get taught that, oh yeah, if you find an oral cancer, that's a one-time, you can save your patient's life. And then you say, oh, actually, if you find a Barrett's esophagus, then you might be able to help save your patient's life. Well, actually, what you're talking about, not only are we helping save lives, we're actually helping to extend quality years to someone's lives, right? So, 10 years, what I often hear, you're adding 10 quality years. And, if you're intervening with children at the right time, then yes, the reach of that could be much greater.
And to circle back to dentistry, right? Like we're talking now about erectile dysfunction, quality of life, sleep quality, rest, and systemic health, which is obviously so important. But as dentists, we're also helping give our patients the opportunity to be on a trajectory that requires less intervention. So much restorative dentistry is avoidable if we get them on a more optimal health journey. So even as dentists, we're changing their quality of life, yes, and we get all the warm fuzzies of increasing their life quality and maybe longevity, but we're also helping them not have to put out fires and suffer through unnecessary dental work as well.
So let me give you patient 4.
Oh, yeah.
Patient 4 is Bob. Bob's your patient in your practice. He's been there for years. He was there when you bought your practice. And you don't know if he's ever really liked you because he's kind of cranky. You can't really get a read on him. He's just like, he's a bit older. He's bigger. He's kind of crotchety. And you're like, I don't know, like, does this guy like me? Is he going to leave my
What
practice?
does crotchety mean? I just want to what does crotchety? That's the first time in my life I've heard that.
Oh, man. It means cranky. Like, cranky. Yeah. So you, think he's going to leave your practice. And you kind of don't mind if he does, because you've been saying, Bob, you need a full mouth rehab. You got acid reflux. And he's like, I'm on my reflux medication. I don't want my teeth fixed. Because he doesn't feel good, and he doesn't feel good in himself. So what do? You start saying, well, Bob, I know you're on the reflux medication, but it's still there, clearly, because you just choked up a bunch of phlegm sitting here, and you just complained about your heart pain. I think you should get a sleep test. And you say it every 6 months. I don't want to give you a solution. This is what John Coy says, and I love it. I don't want to give you a solution to a problem you don't have. But I am seeing some signs that could be related to sleep disordered breathing. So, talk to your primary care. He doesn't want to hear it from you, and he doesn't need to. He finally goes to his primary care, and then all of a sudden you have this book, Breath, in your lobby from James Nestor, which is great because it's written by a journalist who's amazing and funny, and he swears in his book, and people like reading it. And so you have it in your lobby, and one day Bob comes in and he points to the book and he goes, I have sleep apnea. And you go, well, Bob,
oh, shit.
I've been telling you that for a long time. But he goes, have you read this book? I go, well, Bob, it's in my lobby. Of course I've read it. But so Bob is finally ready to talk about it, because you know what? He had that sleep test and he goes, I didn't ask the question until I knew you'd been talking about this, but my physician said, Bob, I'm worried you're going to have a heart attack. And sometimes that has to do with sleep apnea. And he goes, my dentist thinks I have sleep apnea. And now you got two people coming together for the common good of Bob to help him where he's never really felt helped. And now Bob, he has a sleep test and I say, great. He goes, how can you help me? I say, I think you need your sleep test. And I think there's a chance you're going to need a CPAP, and that's okay. And because he gets his CPAP, the next time he comes in, he's happy as a clam. He's lost 25 pounds. He's got a new girlfriend and he wants his teeth fixed. So now you have a full mouth rehab and you save somebody's life. And in turn, not did you only prolong their life, you made a really cranky man really happy. So you improve the quality of their life as well. So the first three patients either self-referred or referred over, but these patients are in your chair every single day and they're asking for help. Like they're coming to you for a reason. Bob didn't leave because he knew there was something else, even though I don't think he liked me very much. But I mean, I think there's just a lot of opportunity for us to do better for our patients. We see our patients more than they see their doctors. And you can take a blood pressure and you can see that it's high. And then you can ask why, especially if they're on medication. But sometimes it's sleep-related breathing disorders. So I don't know, that's my little soapbox, my 2 cents. You want to talk about patient 5?
I'd love to. I mean, firstly, I just want to emphasize again how much I'm enjoying this chat with both of you and how we're making it tangible. You know, one of the taglines of this podcast is making dentistry tangible. And this space within dentistry, you know, is putting the mouth back in the body and it's so exciting to talk about. But there's much more I need to do on the podcast to talk about it. So, you know, formally, these are some themes that we've never touched on the podcast for. So I'm very grateful for that. And so, yeah, patient 5, right? His name is Sihan. He's now 2 and he was exclusively breastfed up till age 1. Okay, so that's fantastic, I think. So well done to my wife. But I'm always very careful when I talk about this because I'm very mindful of the fact that there are some women who are unable to because of life circumstances or whatever. But those, if you're able to and you can breastfeed your child, I mean, what a great start to life you give your child. And I'm sure this is something that you talk about and helping to work as a team with their, you know, lactation consultant, whatever they're called. And so I was really proud. Did you know, you probably know the stat, only 1% of women are breastfeeding at month 6 in the UK. Only 1%.
And you know what's wild? The world guidelines, not to put even more stress on families, they want us exclusively breastfeeding until age 2, I believe is the...
I think it was age 2 as well.
Because the US just changed their guidelines as well. And like we have a epidemic of maternal stress and postpartum anxiety and postpartum depression. And a lot of it is on feeding and the stress associated with it and the metrics and what does my app say? Did my baby get enough to eat? It's maddening. You're right. This can be a very sensitive topic, but women should be able to be given the choice and the assistance to breastfeed if they're able.
And can I add one thing to that too? And so, yes, we always go into breastfeeding kind of like you just did, Jazz. Like, if you're able to, if you can, because we don't want to add more pressure to one of the hardest chapters of life, which is postpartum, especially when you don't get enough maternity leave or you have a baby that has other issues. So maybe that is the path of least resistance to choose to bottle feed or you're unable to breastfeed. But knowing the importance of breastfeeding, even for families that don't breastfeed, can still be a superpower because now you know your child is at risk for not having optimal development. So great, roll up your sleeves and add in other things that can help counteract that rather than be like, oh, well, now that my baby's on that growth.
Yeah, you haven't missed the boat. There are still things like we were discussing.
Exactly. So great if you can. And if you can't, okay, well, you at least are aware of why you should or would optimally be able to. So let's see what else we can add in so that there isn't such a huge deficit.
He had 1 year of breastfeeding, but then now, like, why has he got crowding? He's got deciduous teeth, right? And you should not have crowding in deciduous teeth. Am I right? Would you agree with that?
You should have positive spacing.
Spacing.
If there's just teeth are touching in the deciduous dentition, that is crowding.
And so not only he's got teeth touching, but his centrals are slightly imbricated, like his A's, right? And so he's had that since they've come through. I'm like, how does this work? But then, of course, he had moderate sleep apnea. Now, at the time when he was diagnosed, I think they said it because in a publicly funded system we have in the UK, they probably don't test very many 1-year-olds. I was a very adamant parent because I've been through my first child and now I saw the benefits of an airway intervention had on him. And I was like, I knew something wasn't right with Sihan because of how much he was waking up, his snorting, his stopping breathing, all these factors, right? And so I pushed for it. And yes, his sleep score was even worse than my firstborn's. So breastfeeding, great, big tick, but he still has crowding. And I love what you said, Liz, you said earlier, right? Posturing your mandible forward. And he smiles like that sometimes. He loves to go in that position. I always joke that's his purple minion position. You know, purple minions, right? So that's his purple minion position. So, you know, you probably see children like this all the time. As a parent who has real concern, that's why I've always been pushing and real interest in helping him thrive, what should I do?
how stressful to know that there's a problem and then not know what to do.
So breastfeeding was good for a year.
Yes.
There's a chance that even on the first day of life, there was some compromise to the latch that didn't lead to the turbinates clearing, because that's what happens with first latch. Is as first latch is appropriate, there will be a distraction breath that occurs because babies are born with congested turbinates. There'll be a distraction that occurs as they take that first breath while latched that clears the nasal cavity, because there's like the whole thing with the birth crawl, and there's a whole timing that's supposed to be physiologically appropriate, and that's often interrupted with modern day intervention to make sure a kid's healthy. Maybe there was medication on board, maybe there was C-section, so everybody's birth journey is different. At the end of the day, at least we got a healthy kid. But there's a chance that many of our children, that latch was disrupted, the nose was blocked from the get-go, increased the resistance, and led to, even in the presence of breastfeeding, some type of acid reflux that was continuing to block the nasal cavity.
One thing it took me a while to learn was that the acid reflux causes more inflammation, causes more congestion. So it's not just detrimental to the teeth in an infant that doesn't have teeth, it's causing more swelling, more stuff, and decreasing that negative airspace.
And depending on who you talk to, everybody's going to have varying opinions on why adenoids and tonsils get enlarged. There's going to be many reasons adenoids and tonsils get enlarged, but in part, that acid and that presence of inflammation can have a huge impact on that tissue that's trying to fight a battle of harmony for the system. So for a child of that age, there's a pretty good chance that the adenoids and potentially the tonsils are quite enlarged. The other thing, and this probably isn't you guys, but when we talk about environmental stuff, there can be nutritional impacts, especially I hear a lot of gluten and dairy sensitivities, especially here in the US. We have mold in our homes. We have different viruses.
Just to add on the diet, Liz, if you don't mind, I recently bought this like home blood test, which tells you all your sensitivities and whatnot. I bought it for myself, but actually I have a very good system, and I knew my wife needed it more than me. I kind of said, Sim, you need to do this, okay? And lo and behold, severe dairy allergy, severe allergy to casein, the protein in dairy, mushrooms, cashews, so many things that she enjoys. And so they're everywhere, right? And so it's our duty to get tested, and that could be part of it as well. I mean, maybe my son has it.
And so that's the thing, is like, you can't go back in time and say, well, if we'd eliminated dairy, we wouldn't be having these issues. All we can do is look at what's sitting in front of us and work for better. And so for a kid like that, there's a pretty good chance that adenoids and tonsils are significantly enlarged. Maybe it's as simple as putting them through a nutritional panel to see where we can make changes to reduce that inflammation, putting them on some type of naturopathic path. And again, I don't do that. I guide that through other naturopaths. Many of the families we look at are minimal intervention. They don't want surgery, and nor do I want that for your child. But I also tell people that noise that you were hearing earlier in my background, that's my dryer vent. If a dryer vent is closed and clogged up with gunk, it needs to be cleaned out. And that's kind of the way I describe this. Adenoids are clogging the tube. They either need to be reduced in size naturally, or they need to be surgically intervened on so that a child can breathe. But at that age, it's going to be difficult to say, well, let's expand them. There are a couple of dentists who've expanded or increased the oral volume of the oral cavity with aligners at that age. Is it something that you would always recommend to a patient? No. Is it something that you could do on your kid? Potentially. But I would always talk to the ENT first with that age group, because at the end of the day, depending on the age of the child, the lack of breathing that's occurring can have a different implication. It can have an IQ impact. It can have a behavioral impact. And that can be really like systematically broken up by age. So that's where I want that kid breathing as quick as I can for patients.
And Jazz, like you're seeing, it's already causing a growth change, right? He's got crowding, he's posturing his lower jaw forward. So, Liz is spot on. Working with an ear, nose, and throat doctor, I would add in there, if you have access to in our country, it's SLP, a speech language pathologist that has functional feeding therapy, to start to optimize the muscles so that he can start to grow that really reactive bone by having his tongue posture in the correct position whenever he can. Using a growth guidance appliance of that age to help chew and develop muscles is really important. And then Other things outside of the things that we've already mentioned, have a HEPA air filter in the bedroom. Introduce in a really non-threatening way saline rinses or nasal rinses. You know, in my family and growing up, we would use nasal sprays or neti pots when we were sick. And so it was this thing that we dreaded because we were sick. We didn't feel good. We didn't want anything up our nose. But in an ideal world, that's part of normal hygiene. You brush, you floss, and you rinse your nose. And so while he might have inflammation that's causing congestion because of diet, because of environment, because he missed that first latch, who knows? What can we do? What do we have access to make positive change where we are right now? Maybe we don't have an ear, nose, and throat doctor that's on board because of his age. Maybe we can't do expansion because of his age. Well, what can you do? And I would just say throw spaghetti at the wall and see what sticks. But I will say from my own personal journey, don't hold your kid down and put saline up their nose because then it's a really long battle back to making that fun. So give him like a misting aerosol bottle in the bathtub, something that he can control. And I think the kids are smart, even if they don't understand everything that we're talking about right now. I think that there is this intuition that, hey, I breathe better, I feel better, I sleep better, right?
Well, just to celebrate with you ladies that since he turned 2, like 15 days ago, for some reason, miraculously, he's actually sleeping through the night for the first time in 2 years. So this is huge for our family. So for 2 years, we've struggled a lot. I'm just like, wow. Liz, sorry, did you want to add something, Liz, to that?
No, because I'm talking about like the extremes, right? Surgery and expansion. Maggie's talking about all the day-to-day stuff that we do. And kids are smart. They're intuitive. When mine are in trouble, they'll come up and they'll stand next to me and they'll go, because they're trying to show off that they're nasal breathing so they're not in trouble anymore. Like, you guys are, oh man, little manipulators.
Wow. I just want to say this was absolutely amazing. I'm so glad we connected and we shall meet at AES. But
Yay.
I really want you to just talk about your education that you guys provide, because whether you have docs from the US or docs from the UK who's going to make that trip over, which I would love for them to do, and I myself am thinking I need to learn more about this as well. How can we learn more? What are the channels that you provide? Where are the websites where we can follow you to learn more about this wonderful thing that you're talking about?
Well, you talked early on about our journey, right? Like our evangelism, our educational resources is a journey, and we're constantly adding and changing things. So right now, I would suggest going to our website because we have a resource page that has one of the questions we get all the time is, where's the research? We've compiled a lot of research and we have access to that on our website.
Hundreds of articles. It's amazing.
Yeah, good. Because one question actually I wasn't asking is the evidence base. You know, there's a lot of controversy, especially around orthodontics and airway, right? There's a lot of controversy, let's face it. And so is it like in the world of occlusion, a lot of what we follow and what we teach is not evidence-based because you can't get the studies. You can't get a randomized controlled trial when everyone's got different height of ramuses, different tooth time contact, different facial structures, different dietary habits. How can you disprove anything? And so where are we at with Airway? I mean, it's great. We're talking about that on the Wheel website. Will be a great place. I'll put that in big letters for everyone to click onto because everyone needs to do their own research and homework and make sure that there is a good scientific basis and foundation.
You know, we said this at the beginning, we didn't have a really clear path forward. There are unbelievable resources out there for education. And because we're at a time where science is catching up and there is more research to support what we've been seeing and have seen clinically for decades, it's easier now to jump in than it was maybe 10 years ago when we jumped in. So we're trying to make the journey easier. So while there's so many different platforms out there for education, we want to create what's worked for us. So we have compiled our research. We have an email that goes out daily to drip information. Like, how nice is it to be spoon-fed, easily accessible information without having to commit to hours at an end. And we're also super excited because we have recorded our first course, which is going to be on demand. And it's going to be a really big overview of kind of this podcast, but a little bit more in depth on each section within a course library that has how we do things in our office. And then we're going to offer monthly one-on-one office hours with us so that we can talk real time about individual cases, case number 6 through 100, right?
Because a lot of it's the decision tree and just knowing where to go next. And it's not hard when you wrap your head around it. But that's what I'm really, Platform the Untethered Way, it's just going to be such a great space for people who are really trying to dive into this. And Maggie's always talked about the concept of babes, littles, and bigs. So babies, children, and adults. And we kind of have it segmented out into that to make things a little bit like in this, it's like a mind dump, right? In this podcast. But we can really start to compartmentalize optimize all the age groups based on what we're seeing, and then know how to control the controllables from there. And that's what I think our course will do a good job of. So definitely check it out. Sign up for the email list. It's going to be amazing. And then AES, like we have two, it's AES, American Equilibration Society. It's in February in Chicago. Jazz and Mahmoud are going to be there. It's going to be awesome, but it's very occlusion and joint heavy. And the conversation of airway hasn't always been at the forefront of it, but I'm super excited. We have Tracy Wynn and Jeff Rouse on our stage this year. I'll be there because I'm helping organize it, but we would just love to have everybody join us in person, because in the first time I was there, someone was fighting about how the maxilla causes the problem and someone else was fighting about how the mandible causes the problem. And when you have two incredible world-class speakers like going toe-to-toe on a stage, it's fun dialogue that you can have.
The panel discussions are a great highlight when I attended 2 years ago now, and I'm excited to listen again and share a little bit. But honestly, the lineup you guys have brought me and Mahmoud aside, I mean, if you look at the actual names you got Rockabado, you got Lastman, you got Jeff Rouse, you got some amazing names. So I will put the links to all that, but also to Untethered for the email list, also resources and the on-demand course. So ladies, you have your day to start now. After this, it can only get easier from here. You guys did a wonderful job on this podcast, and I really enjoyed. I was learning. Thanks for patient number 5. It was like a free consultation for me. So thank you so much.
So much fun. Thank you for having us and letting us spout our excitement.
Yes, we really appreciate you.
For those who are listening on Spotify, didn't actually get to see it. For those who watch on YouTube and stuff and got to see it, you could see that at points Liz was jumping to I loved it very much. Thank you so much. Well, there we have it, guys. Thank you so much for listening all the way to the end. Didn't I tell you that'd be interesting? Listen, Protrusive Education is a PACE approved provider. You can get your CE credits or CPD. This episode's 1 hour CE credit or 1 hour CPD, depending on where you are in the world. If you want to collect your CE, you have to answer a quiz and get 80% at least. Go to protrusive.app. Or for those of you who are already on the Protrusive Guidance app, scroll down, answer the questions, and get your certificate. You've done the hard work. You've listened to the episode. Now's your chance to consolidate your learning, and don't forget to download your premium notes. Every episode we do, we create these premium notes. We also have a transcript of every episode, and our premium members can download all of this. Don't forget to check out Liz and Meggie's website, and I'll put that on there as well, so you can check out their resources and education they have. More power to these fantastic women for sharing everything they know, for sharing their journey so selflessly and so compassionately. I had a lot of fun on this episode. I hope you guys did as well. And if you did like it, please do hit that subscribe button. It helps us a lot. And with that, I just want to say one last thank you to my team. You know, without Team Protrusive, there would be no podcast. I would be totally burnt to toast, completely burnt out. And it's only through the team looking after the video editing and helping with the premium notes and quality controlling that I can continue to hopefully sound as enthused as I was on day one. So thank you, Erica, Jan, Chriselle, Marie, Julia, Nav, Hannah, Zaira. As you can see, the team is growing every few months. And of course, the podcast is growing. Thanks to you and all the supporters of Protrusive. I appreciate you very much. So again, catch you same time, same place next week. Bye for now.